A middle-aged homeless man is brought to the ER because of very severe pain in his forearm. The history is that he passed out after drinking a bottle of cheap wine, and he slept on a park bench for an indeterminate time, probably more than 12 hours. There are no signs of trauma, but the muscles in his forearm are very firm and tender to palpation, and passive motion of his fingers and wrist elicit excruciating pain. Pulses at the wrist are normal. This is another example of a compartment syndrome. You know it is a compartment syndrome from the description. Now, the way it happened, you can kind of guess it. The man fell asleep on a park bench, not the most comfortable place. He may have had his arm under where he cut off the circulation to the forearm. And because he was anesthetized with the alcohol, he never moved for 12 hours. When he then wakes up and reestablishes circulation, he gets the compartment syndrome. And the fact that the pulses at the wrist are normal do not rule out the diagnosis. Remember, you need only a pressure of about 30 millimeters of mercury in an affected compartment to destroy that muscle. So he could have, if he has a blood pressure of 120, he could, if you subtract 30, he could still have palpable pulses beyond. So don't let the palpable pulses dissuade you from the diagnosis. This is a compartment syndrome. Remember that the passive extension of the fingers elicit excruciating pain is a very good sign, and he needs a fasciotomy. Vignette number 45 says a patient presents to the ER complaining of moderate but persistent pain in his leg under a long leg plaster cast that was applied 6 hours earlier for a fracture. The point of this vignette is you don't give pain medication and do nothing else for pain under a cast. You have to examine that extremity. So the correct answer is remove the cast and see what's going on. There may be a compartment syndrome. There may be a piece of wadding from the cast that is ulcerating the foot. You don't know. You need to examine the extremity. We're now going to read vignette number 46. A young man involved in a motorcycle accident has an obvious open fracture of his right thigh. The femur is sticking out through a jagged skin laceration. An open fracture is an orthopedic emergency. Within 6 hours, it has to be clean, put together in the operating room, otherwise osteomyelitis will ensue. And I have another orthopedic emergency, vignette 47. A front seat passenger in a car that had a head-on collision relates that he hit the dashboard with his knees and complains of pain in the right hip. He lies on the stretcher in the ER with the right lower extremity shortened, adducted, and internally rotated. This is not a fractured hip. Remember, the fractured hip was shortened externally rotated. This is shortened internally rotated. This is posterior dislocation of the hip. And why is that here with orthopedic emergencies? Remember, we point out that the femoral head has a very tenuous blood supply, particularly in older people. It needs the blood vessels that come through the neck and those that come from the acetabulum. So when that femoral head is outside the acetabulum for a long period of time, it could die. So this needs to be immediately addressed. And now we move to vignette number 48. A healthy 24-year-old man steps on a rusty nail at the stables where he works as a horse breeder. 3 days later, he's brought to the ER moribund with a swollen, dusky foot in which one can feel gas crepitation. Obviously, this is gas gangrene. This patient needs tons of intravenous penicillin, immediate surgical debridement of dead tissue, and after those two things, a trip to the nearest hyperbaric chamber for hyperbaric oxygen treatment, which has been shown beyond any doubt to be helpful in the treatment of gas gangrene. It inactivates the venom, the toxin that the bug produces. Let me point out to you again the picture that you just saw a minute ago of a gentleman with gas gangrene, because the arrows are pointing to all the gas in the tissues. You recognize that this would be a vignette in which a person had a puncture wound in that area in a very dirty environment, and then a couple of 2 or 3 days later would be very, very toxic looking and very sick, and this is the radiological appearance of gas gangrene. And now we move to another chapter under the heading of associated neurovascular injuries. There are going to be some orthopedic vignettes where the broken bone or the dislocated bone are not the big problem. The big problem is what happened to a nerve or an artery nearby. I have 2 examples. A 48-year-old man breaks his arm when he falls down the stairs. X-rays demonstrate an oblique fracture of the middle to distal thirds of the humerus. Physical examination shows that he cannot dorsiflex, extend his wrist. You remember that the humerus has a little spiral groove in the back, and that's where the radius nerve goes, the radial nerve. And so the radial nerve can get trapped in one of these fractures. Now, if you reduce the fracture, put him on a cast, and the function of the nerve returns, you don't need to intervene. But on the other hand, if a patient came with good function, you put him on a cast, and now he cannot dorsiflex, then obviously the nerve has been entrapped and surgery has to be performed. So essentially, what is the ultimate status of that function? If a patient leaves the ER able to dorsiflex his hand, he doesn't need intervention. If he has inability to do that, we may need to go and free the nerve. And now we move to vignette number 50. A football player is hit straight on his right leg, and he suffers a posterior dislocation of his knee. We're showing you a picture of a posterior dislocation of the knee. And the point of this vignette is that right behind the knee is a popliteal artery. And with a posterior dislocation of the knee, the popliteal artery can very easily be occluded. And because there is very little collateral circulation at that point in our anatomy, this could lead to death of the lower extremity. So the key issues are: look at the integrity of the pulses, do an arteriogram, look at the Doppler signal, do immediate reduction, because the problem in a posterior dislocation of the knee is not the ligaments, it's not the capsule, it's what's happening to the popliteal artery. And we move to another little subheading: injury patterns of second hidden fracture. We in fact have already talked about this, but now we're going to repeat some of these. A window cleaner falls from a 3rd-story scaffold, lands on his feet. Physical examination and x-rays show comminuted fractures of both calcanea. That's the obvious injury. But if you know how this happened, you realize that other bones may be on the same line of force. You may want to check the lumbar spine and the thoracic spine for hidden injuries. Vignette number 52, in a head-on automobile collision, the unrestrained front seat passenger strikes the dashboard and windshield. He comes in with facial lacerations, upper extremity fractures, a blunt trauma to his chest and abdomen. All those are the obvious injuries he has. But if he hit the dashboard and the windshield, the dashboard he hit with his knees, that could have driven his femoral head out the back. He may have a posterior dislocation of the femoral head that is not immediately apparent because of all of the other injuries. You better check for that one, because if it's missed, remember the vascular supply is a problem there. And then the final one of these little series is sort of the ultimate hidden injury, and we've talked about it already. The unrestrained front seat passenger in a car that crashes at high speed is brought into the ER with multiple facial fractures and closed head injury. Remember, the head is connected to the rest of the body by the neck. If you have severe head trauma, chances are you may have sustained neck trauma. And remember the thing to do? That CAT scan that you need for the head, go ahead and keep going, include the neck. So the CAT scan of the head should also include the neck.